Okay, thank you so much, Sarah, for this very kind introduction, and welcome everybody for joining us today. So over the last few years, many new developments have been going on and new insights have been derived in prostate cancer grading and precursor lesions. And I'm very excited to share those new insights with you today. So the coming 45 minutes, I would like to discuss the following subjects together with you. First, I'm going and talk about prostatic preneoplastic lesions. That is also attaching to actually the consensus meeting we had 2 years ago in Florence. We will discuss diagnostic criteria, clinical impact and grading, and a little bit on pathogenesis. Then we go into cribriform pattern volume. We all know that cribriform pattern is a very important prognostic factor in prostate cancer. But now we go and look in more details on what cribriform pattern, if the quantity matters, yes or no. And then finally, we go and look into the quantification of Gleason pattern 4. Some very exciting things have been going on there as well. So I hope you will join it coming 45 minutes. So we will start off with preneoplastic lesions of the prostate. And as I already briefly mentioned, this closely attached to our consensus meeting 2 years ago in Florence, in which we discussed precursor lesions of the GU tract. And what I will discuss today are mainly the precursor lesions, of course, in the prostate. So first, when we talk about prostatic preneoplastic lesions, first I want to make clear, for me, this is just a morphological definition. I would define that as an atypical luminal epithelial cell proliferation within pre-existing prostatic glands having retained basal cells. So although we will call it a precursor lesion or preneoplastic lesion, it doesn't always have to be a precursor or preneoplastic lesion. I will come back to that later. So, of course, you all know that there are 3 kinds of precursor or preneoplastic lesions in the prostates, and those are prostatic intraepithelial neoplasia, atypical intraductal proliferation, and intraductal carcinoma. And I'm sure you're all aware that there is a kind of derangement in these precursor lesions. So PIN has the least architecture and intraductal carcinoma the worst. And we will come back to that later. So first, prostatic intraepithelial neoplasia. So morphologically, we can distinguish 2 types of prostatic intraepithelial neoplasia, low-grade PIN and high-grade PIN. And actually, those are the first morphological alterations we can see in the prostate, the first neoplastic morphological alterations that are recognizable. So low-grade PIN is generally recognized as a proliferation of luminal cells with enlarged nuclei, but no prominent nucleoli. On the other side, high-grade PIN will have proliferation of luminal cells with enlarged nuclei, but also with prominent nucleoli. So low-grade PIN, as I told you, is generally a papillary proliferation without prominent nucleoli. Well, that's the first quite subtle alteration we can see in the prostate. However, there have been quite some studies on low-grade prostatic intraepithelial neoplasia, and we know it has a very poor inter-observer agreement. Because the alterations are so subtle, it's extremely difficult to really recognize the lesion and to distinguish it from normal prostate luminal epithelium. And on the other side, prostanotic studies have also shown that there is no increased risk for prostate cancer when you look at low-grade PIN. So generally, we do not have to report low-grade PIN. If you would encounter a lesion that would fulfill the criteria, you can just mention it in the microscopy, but you don't have to report it in the conclusion. Well, then one may ask the question, is low-grade PIN then actually preneoplastic? And that would be a good question. And interestingly, if you would do molecular studies, and this was just a molecular study in which we stained for ERK, which is actually a marker for the TMPRSS2 ERK alteration in prostate cancer, and you can already see that it's not only expressed in prostate cancer, high-grade PIN, but also in some of the low-grade PIN areas. So although low-grade PIN doesn't have to be reported, probably it's already one of the first morphologically alterations that we can see in the prostate. Then high-grade PIN. High-grade PIN, as we all know, is quite common. We have some morphological variants. The most common is the tufting high-grade pin, that's about 2/3 of all the pin lesions. Then we have micropapillary and flat high-grade pin on the left side. So in the early days, we also knew something like cribriform pin, but it's very important now to realize that cribriform pin is not considered a subpattern of pin anymore, but all what we used to call cribriform pin will now be called atypical intraductal proliferation. And probably that's a far more aggressive lesion than the ordinary pin lesions we are looking at. So I will come back to that later as well. So many studies have looked at the prognostic value of high-grade pin in biopsies. And actually we know that if we have all kind of benign biopsies and one biopsy has a small focus of high-grade pin, that doesn't have any clinical impact. So there is no increased risk for prostate cancer on rebiopsy. However, if you have more than 2 or 3 or 4 biopsies that all have high-grade pin, then we know that there is an increased risk of prostate cancer on repeat biopsies. However, if you look at what kind of prostate cancer is biopsies then found in the rebiopsy, that generally is low-grade Gleason score 6 prostate cancer. And actually that's the tumor that we do not want to find at all, because generally that doesn't cause any problems for the patients. There have been few studies that also looked at the differences between flat tufting and micropapillary, and actually they don't show any difference in prognostic value. So what should we do? How should we report it? Well, it's not clear whether we have to report unifocal high-grade pin, because generally it doesn't have any increased risk for finding cancer at the repeat biopsies. Multifocal pin, as we know, there will be an increase of finding low-grade cancer repeat biopsies, but it's really important to recognize here that most of these studies have been done in the pre-MRI area. So there was just a PSA level, a clinical stage, and a biopsy sample. Now, almost all patients will get MRI, at least in our country, and I think that's very important to consider whether one would have to re-biopsy of patients. So if a patient would have multifocal pin but no MRI lesions, it's really the question whether you should re-biopsy immediately or can wait and let the patient come back in 1 year. So this is really for multidisciplinary discussion. So in summary, report multifocal high-grade pin and biopsies, but don't specifically recommend to do repeat biopsies for multifocal pin only. You really have to consider PSA, clinical DRE, and MRI findings. And you don't have to report pin when there is already invasive cancer present in biopsy, and you don't have to report it at all in radical prostatectomy specimens. Then intraductal carcinoma. Well, I'm sure you're all very aware about this lesion. Intraductal carcinoma has been really recognized over the last decade as a very important prognostic and independent prognostic factor in prostate pathology. And it's actually defined as an atypical luminal cell proliferation in dilated glands with intact basal cell layers. Most of the intraductal carcinoma will be of the dense cribriform pattern. So you will have more epithelial atypical cells than luminal space. You can also have the solid pattern, and both can go together with comedonecrosis. So actually most of the comedonecrosis we will see in prostate cancer will be present within IDC and much less in invasive cancer. So that's by far the most common type of intraductal carcinoma. Then sometimes you can also see here tumors that do not fulfill, or lesions that do not fulfill this architectural criteria, for instance, that have loose cribriform pattern or micropapillary pattern, but that have extreme atypia. So atypia that is far more beyond than what's usually seen within prostate cancer, or that have comedonecrosis. Also in these areas, you can call this IDC, though it is very rare. So these are 3 examples. So on the left side, typically cribriform intraductal carcinoma, a basal cell layer was intact there. In the middle, solid IDC with comedonecrosis. Also basal cells were present. one may even think about distinguishing this from urothelial carcinoma or extension of urothelial carcinoma in situ within the prostatic ducts. And on the right side, there's something which is far more rare, very atypical cells within pre-existent ducts that really by far exceed the normal size and atypia found in the prostate cancer. And here again, it's very important to distinguish from urothelial CIS extending into the prostate. So IDC can actually be seen in two scenarios. The one is that you see IDC as a pure lesion, so without any invasive cancer next to it. And that is really very rare. Less than 1% of all IDC lesions are just found without invasive cancer. Now, we know from a few studies that have been performed on these kind of samples that generally this is just a marker for unsampled high-grade prostate cancer. So even when IDC itself is not invasive, you should really recommend to do immediate rebiopsy. And I know there are even some clinics that will do immediate operation if IDC is found on a prostate biopsy. And mostly on rebiopsies, you will find a high-grade invasive cancer that was not sampled in the first biopsy. Well, far more common is when you see IDC adjacent to invasive prostate cancer, that typically would be prostate cancer of a higher grade. So by now, we all know that invasive cribriform carcinoma and intraductal carcinoma, they've both been identified in many studies as being independent prognostic factors in prostate cancer pathology. And personally, I'm really proud of us as pathologists, because by identifying invasive cribriform and intraductal carcinoma as independent predictive factors, we have really changed clinical management. So patients with a Gleason score 3+4 or 7 in the old days would always be actively treated. But now we know that the ones without invasive cribriform and without intraductal carcinoma actually have a very good outcome. And those patients are now really considered eligible to be for active surveillance and don't have to be actively treated immediately. And this is just because pathologists have studied this, and without doing any fancy AI or molecular studies, we can really make a difference here for patients. So I'm really proud of us that we have identified this as pathology group in the world. Well, it is clinically most important, of course, in the grade group 2 patients, the 3+4 patients in biopsies. Actually, we found that invasive cribriform and intraductal carcinoma is prognostic in all Gleason score groups, even in a Gleason score 9 and 10s. So many studies have been going on invasive cribriform and intraductal carcinoma. We know they are both associated with adverse outcome, both considered an exclusion criterion now for active surveillance. But if you go and look more deeper into, they also commonly coexist. They show some morphological overlap in which, by theory, basal cells should be present in intraductal carcinoma and absent in invasive cribriform carcinoma. But that actually is not such an easy criterion, but because look at the picture on the left side. We see two cribriform lesions, and the one on the left has some basal cells, and the one on the right doesn't. Does it really prove that the lesion on the right side is invasive carcinoma? Well, personally, I don't think so. It could just be that this is just an IDC lesion in which the basal cells are not hit in this section of the biopsy. And if you would do deepers, then maybe basal cells would turn up. And that's what we also know for high-grade PIN, that sometimes you can have a few high-grade PIN glands close together, and just one of two of them don't show any basal cells. And so if a cribriform lesion doesn't show basal cells, it doesn't immediately mean that it is invasive. So then there is the grading controversy. Some publications have been going on what to do with grading of IDC. And this is just an example of a biopsy where we have 90% Gleason pattern 3, and then we have cribriform pattern. And based purely on morphology, we do not know whether this is, for instance, cribriform IDC or cribriform invasive carcinoma. So what to do? And there has to be some controversy here in the world on how to approach this scenario. Well, ISUP has said actually quite practical, both invasive cribriform and intraductal carcinoma, they are both aggressive. You don't have to distinguish them. You don't have to do immunohistochemistry. If you see a cribriform atypical lesion, just grade it as if it were invasive. So in this scenario, you don't have to do immunohistochemistry. You would just report Gleason score 3+4, 7 with 10% pattern 4 and invasive cribriform and/or IDC is present. GAPS is a slightly different scenario. They said, okay, if we do not know when IDC is not invasive, we should not grade it. So in that scenario, you would need to do immunohistochemistry. If basal cells were present around the cribriform lesion, you would grade it as Gleason score 6 with IDC, and then add a note that, this probably is just an unsampled high-grade carcinoma, and that these patients should be treated. Well, interestingly, quite some people have discussed these differences, but I think the differences has really a little bit over-exaggerated, because if you really look at how many biopsies are reclassified, regraded, purely because you grade IDC yes or no, is only 1 up to 2% of all biopsy with cancers. Well, we all know that if you do an inter-observer study, the inter-observer variability among pathologists is far greater than 1 to 2%. So probably in clinical practice, this will not have much impact at all. And all pathologists all agree that if you have a Gleason score 6 and you have IDC and you grade it whether yes or no, that the patient should not be eligible for active surveillance. But unfortunately, this difference still exists and may give rise to confusion. So that's why last year at the ASCAP in Boston, we had a common consensus meeting of GAPS and ISUP and discussed together particularly IDC, the criteria, grading, and AIP. And I'm really very happy that we did this together, because now at the meeting, everybody actually agreed that we should report invasive in cribriform and/or intraductal carcinoma, that we can always grade IDC when it is adjacent to invasive cancer. We do not need to distinguish between invasive cribriform cancer and IDC. Grade as if it is invasive disease, and actually never grade IDC if there is no invasive cancer next to it. So I'm very happy that we now all agree in the world on how to approach this. So if you see cribriform area next to it, to prostate cancer, invasive prostate cancer, just consider it and grade it as if it were malignant. So just a few examples. So this is the example I showed you before. 90% pattern 3, 10% cribriform pattern, and you do not know IDC or invasive cribriform. We do not need to do immunohistochemistry. Just grade it as if it were 3, 4, 7, 10% pattern 4, and mention that invasive cribriform and/or IDC is present. There's another scenario: 70% pattern 3, 10% really invasive pattern 4, 20% cribriform, and you do not know whether it's IDC or invasive cribriform. No need for IST, just grade as if it were. So that would be 3 + 4 is 7, 30% pattern 4, invasive cribriform and/or IDC present. And then finally, 40% pattern 3, 20 invasive, and then 40 we don't know. I just grade it as if it, so that would be 4 + 3 is 7, 60% pattern 4. That's actually how to go, and we now all agree in the world how to approach this scenario. So actually, from a biological point of view, I find it very interesting that as soon as you see cribriform morphology occurring in the prostate, that the prognosis of patients will change. So actually, there have been some studies that look at patients with and without cribriform. And actually, if you do not have cribriform prostate cancer, no cribriform pattern, no IDC or invasive cribriform, patients hardly ever metastasize at radical prostatectomy. And so if you have metastasis, almost always you will find IDC or invasive cribriform cancer in your prostate. So why is cribriform pattern so closely related to this worse outcome? Well, biology, the why question is always very difficult to answer in pathology, but there has been some quite interesting studies from a group in Ireland, from Davy, and they have been looking on CACO cells, so cell lines from the colon. And actually, they found some very interesting thing linking genomic alterations to cribriform patterns. So we know that patients with cribriform pattern, either IDC or invasive carcinoma, that they have more genomic alterations and most strongly, more loss of PTEN. And PTEN has many functions, but one of the functions it has is orientation of the mitotic spindle. So when cells divide, this is very strictly regulated. That is always going in the same plane, so that cells will divide in a horizontal way. However, when you have PTEN loss, the mitotic spindle is not able to orient itself that well anymore. And then it can happen that sometimes mitotic spindles will form, not anymore in a horizontal plane, but more in a vertical plane. And that may give rise to these cribriform lesions. So that's how, for instance, PTEN loss may be linked to the existence of cribriform pattern. And cribriform pattern in that sense is mostly just a morphological mirror of underlying genomic instability, particularly PTEN loss. So that's how it may be linked in reality. Okay, then the final precursor pre-neoplastic lesion is atypical intraductal proliferation. And actually that's a proliferation of atypical luminal cells, suspicious for IDC, but not meeting all the IDC criteria. So typically this will be patients with loose cribriform pattern, so that will have cribriform pattern, but there's more than 50% luminal space, so more lumen than atypical epithelial cells, or cribriform pattern in non-dilated glands, and that's what we used to call cribriform pin. Actually, AIP is not really an entity, but it's actually more a diagnosis of uncertainty, just like atypical small acinar proliferations. You think that there will be underlying IDC, but you're not sure. You're not able to prove it here. So these are just two examples that would fulfill the criteria of AIP. Here there's more lumen, and in both there's more lumen than epithelial cells. And so strictly this would mean AIP, but I can imagine that some of you would already consider this like ADC of IDC. So few studies have been done, and many of them come from the group from Dr. Shah, and they have looked, okay, what's the prognostic value of AIP in a biopsy? And if you find AIP and no IDC in a biopsy next to invasive cancer, and you would do a radical prostatectomy, actually we know that patients with AIP in a biopsy also have worse outcome on radical prostatectomy. So that's what you can see on the left side. You more frequently have really large cribriform pattern there, intraductal carcinoma, adverse features. For instance, 2/3 would have PT3, and 1/3 would have Gleason pattern 4 and 5. And so AIP also seems to be a marker for more aggressive disease, and probably is just the edge of an IDC lesion. So we also have discussed on the consensus meeting last year in Boston, okay, shouldn't then we just expand the criteria of IDC and also include loose cribriform? But I think we are not there yet. We are all quite afraid that people will start calling things some high-grade pin lesions that look a little bit more florid than usually, that people may start calling them IDC already, and that would really lead to a much shift in actually patients with low-grade disease to more aggressive disease. And so AIP is still there as a category, and we should diagnose it when we suspect a lesion for IDC, but it doesn't fulfill all criteria. So what did we consented on? Don't just mention atypical intraductal proliferation without note in your conclusion. Urologists generally do not know what to do with that. And so always add atypical intraductal proliferation, suspicious for IDC, then they know what to do. You should always report in grade group 1 and 2. probably in the higher grade group, will not affect clinical management. And we should be careful not to overcall each high grade PIN lesion that looks a little bit more florid as AIP, but really use AIP for lesions that you think will be IDC, but do not fulfill the criteria. And finally, don't grade AIP when it is next to invasive cancer. So then a few slides on the relation of PIN, AIP, and the IDC and pathogenesis. So PIN, we all agree that that is a precursor lesion. So it's the first lesion, first morphological lesion that we can see occurring in the prostate before prostate cancer is starting there. IDC, on the other hand, is mostly found adjacent to prostate cancer and only very rarely without cancer or just next to a Gleason pattern, Gleason score 6 prostate cancer. That's why many people think, okay, IDC probably is not a precursor lesion, but is considered as retrograde spread of invasive cancer into the pre-existent duct system. So the retrograde spread theory is the most popular at this moment for the pathogenesis of IDC. So we actually were quite interested in how would the transitions then of invasive cancer to IDC, how would they look like actually? And we study therefore a set of 50 radical prostatectomies with IDC and characterized those in detail in several ways. Well, the first thing what we found is when you have areas with IDC in radical prostatectomies, very commonly at the periphery, you will find lesions that will fulfill criteria for AIP and even PIN, and that they are almost always found together. More than 90% of IDC lesions would have adjacent AIP and high-grade PIN lesions next to it. In biopsies, you will not always appreciate that, and that's probably just because of a sampling artifact. But in radical prostatectomies, you will see that. Then we did immunohistochemistry for basal cells, and actually our hypothesis was that if invasive cancer would grow back into the pre-existent duct system, that probably basal cells would be pushed inward into pre-existent glands. So all right, I will come back to that later. First, this one. So we first saw that IDC, AIP, and PIN and invasive cancer are often closely adjacent to each other. Often they also have the same molecular alteration. So this was a combined staining of basal cells. Those are red, and P10. And P10 is usually brown, but it is lost in IDC, invasive cancer, and AIP. So often when you have these lesions together, they also have the same P10 expression profile, generally loss. And even, for instance, here, so we know IDC is closely related to P10, but for instance, also look here on this side at the PIN lesion. And you can see the PIN lesion also has loss of P10 there. So we recently finished a study doing more fancy stuff, so-called spatial transcriptomics, in which we look in detail on genomic alterations in adjacent IDC, PIN, and invasive cancer. And there we also find that they are very strongly closely related. So now we will go to the basal cell studies. So actually, as I told you, we had expected that basal cells would be pushed inward when invasive cancer is growing into pre-existing duct system, but actually that's not what we did observe. But what we did observe actually is that if you look at IDC or high-grade PIN or AIP, that quite frequently adjacent to it, you will find glands that look invasive morphologically, but they still have some basal cells. And the farther you go from IDC or the precursor lesions, at the end, you will lose the basal cell layer. And so for instance, look at these glands or those, they look invasive on H&E, but they have some basal cells, and the basal cells are actually lost the farther you go away from the in situ lesion. And I think that's quite difficult to explain if an invasive lesion is growing back into the duct system. And this is again one of those pictures. Here on the right corner, you will see IDC with basal cells, and next to it, clearly invasive glands. but they have retained some basal cells, and the further you go, finally you will lose the basal cell layer. Well, actually, we are not the first one that have found this, and you can actually look at it yourself. If you would have radical prostatectomy, generally you would not do basal cell staining because you can clearly identify the prostate cancer. But if you just do some basal cells, you can really clearly identify those areas yourself. And we've called them invasive adenocarcinoma-like glands. Other ones have called them transitive glands. But they are there and you can just see them and appreciate them yourself. So in the prostate, they will never give a problem. Unfortunately, you can also find these areas very rarely on biopsies. So for instance, this is a biopsy, in my opinion, clearly with an invasive adenocarcinoma, but when we do a basal cell staining, and I don't know why we did that in this case, you could still see that there are some basal cells present in some of these invasive looking like glands. So personally, I would not recommend at all starting diagnosing this as prostate cancer. But I think that if you would have a pattern like that, I would just report it and that probably this is just the phase between the precursor lesion and invasive glands itself. But be aware, this can be found. Actually, this was recognized already many years ago by the group of Dr. Epstein, who also found reported biopsies with clearly invasive cancer, but with retained basal cells. And very anecdotally, this has also been found in metastatic prostate cancer, where you have prostate cancer glands that have some basal cells still around them. So how can we explain that? So based on these observations on these invasive adenocarcinoma-like glands, actually we came to a new hypothesis on how IDC may arise. And we call that the repetitive invasive precursor progression hypothesis. So basically, how do we think that it will go? So you will have normal prostate. The first genomic alterations will give rise to high-grade PIN. At a certain moment, high-grade PIN cells, they accumulate genomic alterations in which they get a potency to invade surrounding stroma. But they do not just break through the basal cell barrier, but they are going and invading the stroma and drag basal cells along with them. So that's why you can see some invasive glands that still have some basal cells. So now, if time is await, a few things happen. First, the invasive part is becoming more invasive, and finally the invasive glands will completely lose the basal cell layer. But as the high-grade PIN cells already accumulated genomic alterations that potentiated them to invade the stroma, then why would that just happen once? And it could happen twice or even more times. Actually, in the study we did, in some of the slides of radical prostatectomy, we found up to 8 invasive foci just within one slide. This may happen all the time. And so this would give rise to another area of invasion. This could also nicely explain why we would see multifocality in prostate cancer. But what could happen then next? So high-grade PIN cells may further accumulate genomic alterations, for instance, P10 loss. And what would happen then? It would just go and proliferate and form cribriform IDC lesions. So this would explain why you can have, for instance, Gleason score 6 cancer and IDC next to it. And IDC then itself, as the cells have already acquired the potency for invasion, could invade again. So this would totally give rise to the very heterogeneous picture prostate cancer usually is under the microscope. But again, this is just a hypothesis. There's not evidence at all yet that this is really true, but I think it's a very interesting way to also consider and try to explain all the features we find. Okay, this is the precursor session. We will close that by now, and I will go into cribriform pattern now. So, as already discussed, cribriform pattern is really recognized as an independent adverse feature in prostate cancer. It can be either invasive or intraductal. Doesn't matter, they are both associated with worse outcome. not only in Gleason score 7, but also an 8, 9, and 10. So as we are now aware that invasive creamiform and intraductal carcinoma are associated with adverse outcome, some logical next questions come afterward. For instance, does the volume of creamiform pattern matter? Does it matter whether you have a biopsy with only one focus of creamiform pattern or whether there are multiple foci of creamiform pattern? Do those patients have the same outcome or not? Few studies have looked into that. For instance, the Canadian group there. And we know that if you have more foci of creamiform pattern, inter-observer reproducibility is getting better. We are agree more that we are looking at creamiform pattern, but it doesn't have prognostic impact. And that may be explained because if you have creamiform pattern, even when you have one creamiform pattern, it means that this is just probably a reflection of underlying genomic instability. So one creamiform area already is a signature of underlying genomic instability. So more foci doesn't really have a worse impact or more prognostic impact. On the other hand, you can also look at creamiform size. When you go and look in a microscope, sometimes creamiform areas, they are small like this, and other times they are large like the one on the right side. And would that have a difference? Well, some studies have really looked at that. And first of that, we know from a diagnostic point of view, large creamiform pattern has a very good inter-observer reproducibility. And if you look on this slide again, this one on the right, probably everybody will agree this is creamiform pattern. However, when you have these very small areas, I can imagine there's really some disagreement and that people may oversee it or would call it differently. So if you have large creamiform pattern, the reproducibility is really excellent. But it is important to realize that according to current definitions of IDC, of invasive creamiform pattern, size is not a criteria. So creamiform pattern is defined as a contiguous atypical epithelial sheet without an adjacent stroma. So many of the tumor cells, they will touch other tumor cells and or lumina, but they will not touch the stroma. This can look quite closely, might resemble fused glands, but fused glands, if you look closely, all the tumor cells are still touching stroma. And that's not the case in creamiform pattern. So probably genomic alterations that are acquired by the atypical cells, they allow them to grow without any stromal contact anymore. So few groups then have looked in detail at the size of one creamiform area and the outcome. And this is really initiated by the group around Dr. Jesse McKenney, Dr. Greenland, and Dr. Jane Nguyen, and they've really put this field forward. And how do you do this? So when you see creamiform area, you would measure the shortest axis, not the longest one, because that could just be tangential sectioning of a duct, but the shortest one. And you can just easily measure that. And typically they found that there is a difference whether such a smallest area is larger or smaller than 0.25 millimeters. So that's what they would call small or large. In the literature, also some other criteria are used. But it seems, and we'll come back to that later, that this 0.25 millimeter is the most appropriate diameter if you want to distinguish small versus large creamiform. So what's usually the distribution of creamiform pattern? So here, if you look at this nice histogram of Gleason score 3+4 prostate cancer, you will see that most of the patients' creamiform pattern will have a size of around 300 micrometer. So 250 micrometer would just be beyond that. And there is a very large tail on the right, with some lesions going up to almost 1 millimeter. Also consider that on radical prostatectomies, when you look at grade group 2 disease, about half of the patients will not have creamiform pattern. Most of them will have large creamiform, and small creamiform is a little bit more rare there. That's important to keep in mind. So if you go and look at the outcome then typically what you see in radical prostatectomies, so if you have radical prostatectomy, measure the size, and then 2 studies looked at biochemical recurrence, and actually they both found that when you have large cribriform pattern, here the blue or this line, actually biochemical recurrence-free survival is worse. And it's worse than small cribriform pattern. And in both series, actually, the difference between small cribriform pattern and no cribriform pattern at all, that was not statistically different. So both series actually pointed towards that mostly large cribriform pattern had independent prognostic value for biochemical recurrence on radical prostatectomies. But that's a radical prostatectomy. And obviously, we're mostly interested in biopsies because at that time, we can still use it for further treatment decisions. So what happens on biopsies? So this again was a nice study on Dr. Greenland, and they looked on patients with grade group 2 biopsies, measured cribriform areas, and then looked at pathological features at the following radical prostatectomy. And quite interestingly, they found when you have large cribriform pattern, so larger than 0.25 millimeter, actually patients have adverse features. So more frequently grade group 3 and 4, more often extra prostatic extension, and actually that this was not the case in small and no cribriform, and in their series actually there was no difference between no and small cribriform pattern. So according to that study, in grade group 2 patients, large cribriform had really worse features, and small and no cribriform actually had similar outcome. In that study, they also looked at biochemical recurrence-free survival after radical prostatectomy. So again, at the biopsy, the cribriform pattern was measured, patient got radical prostatectomy, and then even they found that patients with large cribriform pattern, they tended to have worse biochemical recurrence-free survival. But we should keep in mind that this is all about adverse pathology and biochemical recurrence-free survival. What happens if you look at other endpoints like metastasis-free survival? So several studies have really looked and found that cribriform pattern is very strongly associated with metastatic features. Actually, you will hardly ever find any metastasis if there is no cribriform pattern present in the prostate. So if you look at cribriform pattern and its relation with metastasis, actually you will find something different. So this is a study we have still in the way of preparation. We looked at almost 2,000 biopsies in total. Around 400 patients had grade group 2 on biopsy. And when we looked at long-term follow-up, and long-term here is really long-term, this is not 20 months, but 20 years follow-up. And then you can actually see that patients with small and large cribriform have the same adverse outcome. Though the ones without cribriform on biopsies had much better outcome. So this is a little bit counterintuitive and also a little bit in contrast to the findings of others and also our own findings on the impact of cribriform size on biochemical recurrence. So on biochemical recurrence, it seems that large cribriform is really doing worse than small and no, and that there is no difference between small and no cribriform. However, if you look at metastasis-free survival, both cribriform are worse, and they are much worse than no cribriform. And this is just another way of pointing that with the Cox regression analysis. And you can see no difference between small and large cribriform. So I think cribriform pattern size is still a work in progress. There are really good indications that on radical prostatectomy, large cribriform is associated with worse biochemical recurrence-free survival. But when you go and look at metastasis-free survival, then any cribriform still may be significant. And there may be many explanations for this counterintuitive results. Of course, you could think about differences in cohorts, differences in treatment, confounding factors, but it's always also important to realize one important fact, and that's just that a Gleason score 7 biopsy is not exactly the same as a Gleason score 7 radical prostatectomy. And we know, for instance, that Gleason score 3+4/7 biopsies are very frequently upgraded to higher grade disease at radical prostatectomy, and that's also the case with cribriform pattern. For instance, if you look at radical prostatectomies with Gleason score 3-4-7, 45% will not have any cribriform, and then there will be most patients will have large cribriform and just half of them small. However, if you go and look on biopsies, most Gleason score 7 patients will not have cribriform pattern. That probably is just missed in a biopsy. And if you see cribriform, it's more difficult to really estimate the size. The cribriform pattern can just be on the edge of biopsy. So it's more difficult, or maybe even impossible in some cases, to really estimate and measure the true size. And that's why you can see that there is a large drop in the percentage of large cribriform patterns. So that might also account for the difference between the outcomes of cribriform pattern in biopsies and biochemical and metastasis-free survival. But I hope coming years it will be more clear, what's the true value of cribriform size in practice. Okay, then finally, last 10 minutes, I want to go and discuss some very exciting new insights in Gleason pattern 4 quantity. So we know that Gleason score 7 biopsies are actually the most common that are found nowadays in the MRI area. And many studies are ongoing to develop further risk stratification in these patients. Well, one of the ways of looking at Gleason score 7 is the difference between pattern 3 and 4, and then particularly the quantitative measurements of both. Well, we grade biopsies as the most common and the worst. That means that if you have a grade group 2 biopsy, you could have 55% pattern 3 and 45 pattern 4. That would be Gleason score 7. But the latter one also, 99% pattern 3 and 1% pattern 4, that would also be Gleason score 3+4 is 7. So is there a difference between outcome? Well, this was nicely proven by a huge study from the Hamburg group in Germany, from Guido Sauter, and they really looked in almost 10,000 radical prostatectomies what the impact of percentage pattern 4 was. And quite interestingly, they found that the more percentage pattern 4 you have, the worse the outcome is. And I know in some countries, percentage pattern 4 is also a criterion for active surveillance. It's not in Europe at this moment. Invasive cribriform and IDC, those are exclusion criteria for grade group 2 disease, but percentage pattern 4 is not in Europe, but could well be that in other countries or other centers this may be different. However, if you think about proportion pattern 4, it is really interesting. And this was really initiated by the group in Memorial Sloan Kettering, around Dr. Victors and around Dr. Fine. And they had a very nice studies on proportion of Gleason pattern 4. And just in theory, and I borrowed those pictures from those publications, if you think about the radical prostatectomy with Gleason score 7 looking like this, where you have a large amount of pattern 4, but a little bit larger amount of pattern 3, that would be called Gleason pattern 3+4 is 7. However, if you would have a very small tumor with only pattern 4, by definition, we would have to call it Gleason score 8. So this patient, however, has far less pattern 4 than this one, if you look at absolute quantities. Another way of looking at that is just as biopsy examples. Here we have an example of 3 biopsies, and all biopsies, they have the same volume of pattern 4, 3 millimeter. But the one on top also has Gleason pattern 4 or 3, and the Gleason score would be 3+4, 7. This patient would be favorable intermediate risk and could still be eligible for active surveillance if no cribriform pattern were present. However, the second biopsy has a little bit less pattern 3. This would be unfavorable intermediate risk. Patient would generally not be eligible for active surveillance anymore. And here we would consider definitive treatment. And the last biopsy, no pattern 3 is present anymore. This would be Gleason score 8, so high risk disease and definite treatment. So here we can see that risk classification is not based on pattern 4 volume, but purely on its relation to pattern 3. So what the group in Memorial Sloan Kettering did is they developed models on biopsies, and they included like the routine clinical parameters such as PSA, clinical stage, and then added the absolute volume of pattern 4. So what you actually do then, you measure the total volume of length of cancer in biopsies. You have the percentage of pattern 4, and then you calculate how many millimeters pattern 4 you would have. If you have that model, including millimeters pattern 4, it doesn't add anymore if you add pattern 3 or percentage pattern 4. That doesn't have any prognostic value anymore. So as you know how much volume pattern 4 there is, in absolute quantity, absolute length, it doesn't matter anymore if you add much or no pattern 3. So here the outcome was they started with grade group 2 to 4 biopsies, a combination of 3 and 4 actually, and the outcome was adverse features on radical prostatectomies. Well, we went back to the same series I just shared with you on the large biopsy numbers. So we looked at 2,000 biopsies and actually did the same multivariate analysis. So we added absolute length pattern 4, and it was highly significant for metastasis-free survival. And actually, if you have absolute length 4 in it, the amount of pattern 3 doesn't matter at all anymore. So the prognosis purely determined by the absolute length of pattern 3 and not anymore to the proportion of 4 towards 3. There's another study we did. So are absolute length pattern 4 and percentage then completely independent? No, they are strongly related. Here, if you look in biopsy series, actually they have a very strong correlation, up to 0.7 rho in the Spearman correlation. But if you look at this biopsy series and then compare, for instance, percentage pattern 4 in Gleason score 7 biopsies versus total length pattern 4, then in all the scenarios you have, the absolute length of pattern 4 has a better predictive value for biochemical recurrence. So these are C indexes. It's larger when you go and take into account all biopsies. If you just look at the biopsy with the highest percentage pattern 4, again there, if you look at absolute value volume pattern 4, that is more predictive for outcome than the percentage, the relation of pattern 4 towards pattern 3. So to summarize here, so there are more studies now that show that there is no impact of Gleason pattern 3 volume when the quantity of pattern 4 is known. There's a strong correlation, however, between pattern 4 measurements. So percentage is generally correlating really well to proportion, but absolute length outperforms proportion in statistical analysis. And then the question is, this is very nice theory giving insights. How should you use that in practice? Well, at this moment, I would not recommend starting including millimeters in all your reports. That doesn't have any added value. Where it could have added value is when you go and have biopsies with small tumor volumes that are high grade. So small tumors that are Gleason score 4 plus 3 is 7. And we should just have a few pattern 3 glands, a little bit more pattern 4 glands. Generally, by theory, you would call this Gleason pattern 4 plus 3 is 7, would be unfavorable intermediate risk. But maybe those patients would not behave that aggressively if you just look at purely at the total length of pattern 4. So I would recommend in multidisciplinary meetings, if you have those cases, so with small high-grade volumes, really discuss what's the best option for these patients. So this was the final slide, actually, and I hope I gave you a nice update on what's going on at this moment in the prostate cancer field. And I'm very excited to have been able to share this with you. I'm looking forward to questions and further insights the coming years. Thank you for your attention.
Thank you, Dr. van Leenders. We do have some questions already coming up in the Q&A. Please feel free to add more questions as we go. I think to start, just for sort of a good old-fashioned morphology question, your criteria to distinguish AIP versus IDC.
Okay, the criteria of distinguishing AIP and IDC, IDC is generally a dense cribriform. In IDC, you will have like a dilated pre-existent gland with a dense cribriform pattern. So that means there are more atypical epithelial cells than there are lumina. In in AIP, it's the other way around. So you will have like a distended pre-existing glands, but there are more lumina than epithelium. And I agree, this is quite subjective, but that's currently how the distinction is. AIP also is like what we used to call cribriform pin. So then you would not have a distended gland, but there is a small cribriform area. So that's how we still define it.
All right. One thing I think might be interesting, given the studies you were showing about the quantitation of pattern 4, someone's raised the possibility of why would you not consider invasive cribriform as pattern 5, given that it is more aggressive than non-cribriform pattern 4, excuse me.
Yeah, thank you. That's a very excellent question, of course. And several papers have already suggested that it's quite interesting, actually, because now if we have a pathology report, we have a Gleason score, we have a percentage pattern 4, we have invasive cribriform intraductal carcinoma, and how to combine all this information in comprehensive risk factors. Well, some proof of principle studies have been put forward to combine all those information within one study. And that's not there yet, so that will not change within the coming 5 years. But people are really working on that because it's well recognized that cribriform area has much worse prognosis than the other patterns 4, but probably also has worse prognosis when you compare to, for instance, core-like pattern 5. And so if you would have a Gleason score 9 cancer on a radical without any cribriform or solid pattern, no IDC, actually these patients have a far more better outcome than people generally believe. And so I really expect that some new systems for risk stratification based on percentage 4, percentage 5, and invasive cribriform intraductal carcinoma will come out in coming years.
Yeah, I think it speaks to when you have this many different sort of variables to consider and they're not consistently reported in every case in every country, it's very hard to get that cohort together. Lots of good questions. We only have so much time, but let's look at, let's see, how about the question, does the published ISUP GUPS consensus mention reporting IDC and cribriform invasive carcinoma jointly without distinguishing between them in the presence of invasive carcinoma? I have trouble finding it in the published Shaw paper, while the latter suggests that cribriform IDC might have a different prognostic and therapeutic implication than just cribriform invasive carcinoma.
Yeah, thank you again for this excellent question, of course. So there have been several studies looking whether there is a difference between IDC and invasive cribriform pattern. They do not all have the same results. So a few studies really find that there is no difference, that both are bad news. Very frequently, they are also together present. So our own study, we could not find a difference between it. However, I know there are studies that show that IDC has a little bit of worse outcome. The problem is not always that easy to distinguish IDC from cribriform, invasive cribriform. So the absence of basal cells doesn't prove that you're looking at invasive cancer, but could also be IDC. So I know many people ask this, so should we distinguish then in reporting? So at this moment, we do not have to distinguish that. So if I don't know if I'm looking at IDC or invasive reform, I would just mention invasive reform and / or IDC, and don't distinguish between them. So the presence of any reform pattern is already bad news. Doesn't matter whether it's IDC or invasive.
Yeah, I think there's still a lot of work to be done in our understanding of that. One more question before we stop. In light of the recent ISUP GUPS consultation paper, how would you report an atypical introductal proliferation that is not suspicious for IDC, but displays architectural or cytology beyond that typically seen in PEN? For example, micropapillary to focally loose cribriform.
Yeah, again, thank you so much for this very good question. That was extensively discussed, how to deal with that. So basically, people are really afraid that people will start calling everything that's high-grade pain that's a little bit more florid than usual as AIP. And this really may affect already clinical management. So if you would have a Gleason score 6 cancer with high-grade pain, and people would say, this is AIP, many of these patients probably will immediately go to active treatment because urologists know AAP is generally an unsampled IDC. So I would be very careful just calling all high-grade pain that's slightly more atypical AIP, and really use AIP for things that you think that they are IDC, but they do not fulfill all criteria. But again, here, it's still unclear what it is. So there are just a few studies that have looked at AIP, and there's not really a difference made between the different forms of AIP. So this is not really supported by strong scientific data at this moment. As some people believe that maybe P10 could have added value there. So we know P10 is frequently lost in IDC, and maybe if you think, okay, should I call this AIP or PIN? You could think about doing P10. If P10 is lost, that would favor a little bit more AIP. But mostly reserve it for the category where you think it will be IDC, but it doesn't fulfill all criteria.
All right. Well, excellent engagement today. Thank you, everybody, for your questions and your attention. Our next ISUP Presents will be in February next month with Dr. Gladel Paner, and we will send out an announcement and sign up for that shortly. So thank you today to Dr. van Leenders for joining us, and everybody for your participation. Have a great rest of your day.